I'm Dr. Victoria, and this is George.
Today, we are going to talk about peritonsillar abscesses, sometimes called quinsy. Peritonsillar abscesses are the most common deep neck infection of children and adolescents. For the past 2 weeks, George has not been feeling well at all. At first, he just had a sore throat, and then he noticed the back of his mouth felt very sore indeed, and George was developing a fever. Then George noticed that the muscles of his jaw were very tense, and it was hard to open his mouth. He was having ear pain. It was getting hard for him to eat. He was even drooling a little bit. What is happening to George is that he has developed a peritonsillar abscess. He has pus that is sitting between the capsule of his palatine tonsil and the pharyngeal muscles. This has developed progressively. At first, there was just acute tonsillitis when his throat felt a little bit sore, and then he started to develop cellulitis, and eventually there was a collection of pus so that he had an abscess. Sometimes you can skip right to an abscess by having obstruction of the superior salivary glands, Weber glands, or even smoking is a risk factor for directly developing an abscess. There are many important structures in and around the tonsils. Nearby, there is the internal carotid artery, internal jugular vein, and cranial nerve 10. There are also some important muscles like the internal pterygoid muscle, pharyngeal constrictor muscle, and superior constrictor muscles, which help to form the peritonsillar space. This is important to take note of because if there is an infection in the peritonsillar space, one might develop edema of the larynx needing a tracheostomy, or a patient might become septic, leading to endocarditis, nephritis, or a brain abscess. The development of jugular venous thrombosis is possible, and there could be spontaneous hemorrhage of the carotid artery or jugular vein. Or, because all of that bacteria at the back of the throat, one could develop an aspiration pneumonia. Some bacteria in particular are culprits for developing a peritonsillar abscess. Aerobic bacteria include Strep pyogenes, our group A strep, Staph aeruginosus, and Staph aureus, including MRSA. Anaerobic bacteria include Fusobacteria, Prevotella, Veillonella, and occasionally Haemophilus species. When we obtain the history of someone with a peritonsillar abscess, it may be for an adult or a child, and the pain is usually unilateral, but it may be bilateral. General symptoms include chills, rigors, malaise, body aches, headache, nausea, constipation, fatigue, irritability, and decreased oral intake. Localized symptoms include severe throat pain, dysphagia or odontophagia leading to dehydration because the patient won't drink, a hot potato voice where the speech sounds muffled or thick, foul breath, and an earache on the same side as the tonsil with pain, trismus or lockjaw due to involvement of the internal pterygoid muscles. We don't just see lockjaw and tetanus, and pooling of the saliva or drool. Make sure you have some napkins handy in the exam room. Most exams of this condition will likely show a patient with a sore throat, fever, and hot potato voice. But if the patient is anxious or ill-appearing with drool and posturing, it is important to monitor them in a setting where an emergency airway can be established. The tonsils, pillars, and soft palate may show congestion or swelling. You may not see a swollen tonsil. Often the uvula is swollen, edematous, and pushed to the opposite side where the abscess is. You may see pus on the tonsil. You may see cervical or submandibular lymphadenopathy. There may even be torticollis, where the head is tilted to the side of the abscess. The diagnosis of peritonsillar abscess is made clinically. We get a good history and we do a good exam. But if we are unsure, there are a few things we can do. Helpful are the needle aspiration or an incision and drainage, since this is also part of our treatment plan. But it helps differentiate between peritonsillar abscess and cellulitis. An ultrasound also helps us differentiate between cellulitis versus an abscess. The lateral neck plain x-ray helps us rule out epiglottitis, but hopefully you will be able to see in the back of the patient's mouth to visualize if there is an inflamed epiglottis, so there would be no need to do an x-ray. If we want to rule out deep neck infection, like a retropharyngeal abscess, it is common to do a CT with IV contrast. A lateral neck x-ray may show a retropharyngeal abscess, but is not definitive, and an MRI is not the best choice because it takes longer. You often need to sedate younger children, and the patient would need to go supine. Not the best choice when there is a compromised airway. Laboratory studies help us assess the severity of infection. We look at the CBC for an elevated neutrophil count. Serum electrolytes are important, especially if the patient has had poor oral intake. And a culture, gram stain, and rapid antigen test to look for group A strep. Culprits of particularly severe infections, often with a bilateral presentation, include Epstein-Barr virus, herpes simplex virus, Coxsackie virus, adenovirus, diphtheria, group A strep, and gonorrhea. One of the most important parts of our treatment are knowing if there is a possibility of an airway compromise. In general, most of these patients need to go to the hospital. The most important components are to drain, provide antibiotics, and provide supportive care. At the hospital, they can get IV fluids and IV antibiotics. If it were cellulitis, antibiotics alone would be sufficient in most cases. For an abscess, drainage is needed. Good oral hygiene with the help of hydrogen peroxide or saline mouthwash will be helpful. If it was not part of our diagnosis, incision and drainage of the abscess or needle aspiration, even better if it's done with the use of ultrasound, can be done, and possibly a tonsillectomy. Tonsillectomy can be done immediately or after the acute infection. There's a risk of bleeding with this procedure. Doing it in the acute setting minimizes any loss to follow-up, but may be technically more difficult if there's fibrosis and scarring after the acute infection. Again, if it is only cellulitis, antibiotics alone should be sufficient. If the patient with a peritonsillar abscess is cooperative and able to self-hydrate, they may require antibiotics alone as well. Parenteral treatment includes ampicillin sulbactam or clindamycin. It is important to check the local susceptibility of our likely bacterial culprits to antibiotic treatment. What works for patients where I live may not work where you live. If there is no response to treatment, or if the patient presents with severe symptoms, you can add IV vancomycin or linezolid. We want to continue parenteral treatment until the patient no longer has fever and is clinically better. Once this is achieved, the patient can be transferred over to oral antibiotics, but make sure that the total treatment duration lasts for at least 10 days, and it's best to have 14 days of treatment to prevent a recurrence. Oral antibiotics are often amoxiclav, clindamycin, and if you used it, vancomycin. Glucocorticoids are sometimes used, but it is important to monitor for rebound swelling of the tonsils after the last dose has been given. We must monitor that the tonsils do not get large again, otherwise they are going to show up at our ER shortly after being discharged. It is important that someone with a peritonsillar abscess or cellulitis to follow up with their primary care provider so that they can be re-evaluated for any shortness of breath, worsening throat pain, neck pain, trismus, any enlarging mass, fever, neck stiffness, or bleeding. If someone is just being managed in the outpatient setting, it is important that they be seen again after 24 to 36 hours. If they are being discharged from the hospital, they should be seen in the next few days with their primary care provider. The prognosis is quite good, and most abscesses are resolved with no long-term problems. But in 10 to 15%, there can be a reoccurrence, especially if someone already has a history of recurrent tonsillitis before they got their abscess. For George, well, I am quite worried about his ability to breathe and the fact that he has not eaten in a couple of days. I'm going to send him to the hospital so that he can get an IV put in to get him some fluids and antibiotics. As well, I'll schedule an incision and drainage. He might stay there a couple of days, but I'm sure he will be back to his old self in just a week or two. George really has a lovely singing voice, and we will get him back to bringing joy and merriment to those around him. Thank you for joining me today, my healthcare team. I hope you will join me next time as we see what George is up to next. Bye-bye!